So let's now talk about the phases of wound healing. This is a very important topic. This was asked in the UPSC exam and also in the INI CET exam. So you should know that there are 4 phases of wound healing, and these have also been covered by Dr. Illa. But I'll be covering this in a bit of detail because there are certain clinical questions which I want you to know for the exam. So the 4 phases are hemostasis, inflammatory, proliferative and remodeling. So this is the order in which these phases occur. Firstly, whenever there is any injury, first hemostasis happens. And once the hemostasis part has been taken care of, then within 48 hours, inflammatory process is going to be started. And within 48 hours, the dominant cell is the neutrophil. The dominant cell is the neutrophil. So if you look at this graph, these are 2 graphs which you should know about. So this tells us about the dominant cell in wound healing. And you can see here that the inflammatory phase lasts from 0 to 2 to 3 days. Now, one more thing which you can see is that these phases are overlapping. So it is not a hard and fast rule that inflammation would only be for 2 days or 3 days. Some of the phases, there is some overlap which is present. So the inflammatory phase you can see can last from 0 to 4 to 5 days, and at 48 hours the dominant cell is the neutrophil, which is the dominant cell. And then you will see that by the 4th day, this dominant cell starts getting replaced by the macrophages, right? So macrophages will come in by day 4. These are the macrophages, and they will start clearing out the debris. And they will pave the way for fibroblasts to come in. Okay, they will pave the way for fibroblasts to come in. So this orange one are the fibroblasts, and this is what starts your proliferative state. So in the proliferative state, what is going to happen is that there is going to be deposition of collagen. And which collagen will get deposited? So you have to see here, this is also very important, that initially you have type 3 collagen which will be deposited. Okay, so type 3 collagen gets deposited, and this is in a disorganized manner. This type 3 collagen gets deposited in a disorganized manner in the proliferative phase. So when the proliferative phase gets over, then the maturation phase starts, where there is reorganization of the collagen. And you can see in the maturation phase, collagen type 1 becomes the dominant collagen. Okay, collagen type 1 becomes the dominant collagen, and this is collagen type 1. And collagen type 1 to type 3 ratio becomes 4:1. In a mature wound, the ratio of type 1 to type 3 collagen becomes 4:1. Okay, so let me just summarize everything what I have said. There are 4 phases. Hemostasis occurs early. This is the first response of the body to stop the blood. Then the inflammatory phase is going to start. The inflammatory phase is going to last for 2 to 4 days. Right, 2 to 4 days, and the dominant cell here is neutrophil. After the 4th day, neutrophils are replaced by macrophages. Neutrophils are replaced by macrophages, which will clear out all the debris in the wound. And the proliferative phase is when fibroblasts play a major role. So from day 5-6, fibroblasts will also come in, and these fibroblasts are going to play a major role. And initially, type 3 collagen will be deposited in a disorganized fashion. Type 3 collagen is deposited in a disorganized fashion, right? And this ratio, when type 3 is being deposited, it can go up to 8:1 as well. That means 8 times type 3 collagen is there, only 1 time there is type 1 collagen. So 8 times more type 3 collagen is there. But this is all in a disorganized manner. Remodeling is going to start from 15 days to 1 year. 15 days to 1 year remodeling can occur. And what occurs in remodeling is that type 3 is replaced by organized type 1. by type 1 collagen. Why type 1 collagen? Why not some other collagen? Because type 1 has the highest tensile strength, and type 1 to type 3 ratio, this question was asked in the exam, is 4:1 at the end of the remodeling phase. So these are the 4 phases of wound healing. Again, to go over the graphs with you. In the initial few days, neutrophil is the dominant cell for the first 48 hours. Then macrophages for 4 to 5 days. Then fibroblasts come into the picture and they deposit your collagen, right? The matrix synthesis, initially it is type 3 collagen and then it is replaced by type 1 collagen. I've already told you the ratio is 4:1. One more thing which you should know about wound strength. This question is also being asked in the exam. Wound strength after any injury or any trauma. This is 10% at the end of first week. At the end of week 1, it is 10%. And it is 70 to 80% at end of week 12. At end of week 12, it is 70 to 80%. It never regains 100% strength. That is another question which you should know about. It never regains 100% strength. So these are the points which you should know regarding wound healing. Now, one more thing which I want you to know, what are the factors which hamper wound healing, which affect wound healing? So factors which affect wound healing, and we are going to divide them into local factors and systemic factors. So local factors can be presence of a foreign body. So if the foreign body is there, it will not allow the wound to heal. Also, sometimes patients respond to certain suture materials, so that can form a stitch granuloma and the wound cannot heal. Okay, so foreign bodies. Radiation. If radiotherapy has been given, the wound does not heal, which is why a lot of our patients, when we do surgery and we send them to the radiation oncologist, the radiation oncologist always tells us that let the wound heal, then only I'll start radiotherapy. Otherwise, the wound will never heal during the course of radiotherapy. Infection. So infection is the most common cause. Local infection is the most common cause why a wound does not heal and becomes a chronic wound. So that is the most common cause why a wound will not heal. Another repetitive cause is trauma, repetitive trauma in that area. That is why I'm sure all of you would have observed that if you have a wound over the joint, where the joint movement will always be there, that will always take a longer time for the wound to heal. Okay. The systemic factors: malnutrition, anemia, immunocompromised status. Two more things which I want you to know is vitamin C deficiency. Vitamin C deficiency can give rise to scurvy, and this can hamper with wound healing. And which phase does it affect? It affects the early matrix deposition. So the early matrix deposition, that means the proliferative phase, is the phase which is affected when the patient has vitamin C deficiency or scurvy. One more thing which I want you to know is steroids. So some patients are on steroids for various reasons. Somebody can be on steroids for nephrotic syndrome, or there can be other autoimmune conditions for which the patient can be on steroids. Now, which phase does steroid hamper? Steroid hampers the inflammatory response. It inhibits the inflammatory response, and that is how it affects wound healing. So what is said is that whenever you're doing a surgery, supposing you're doing a surgery for a nephrotic syndrome patient or for anyone who's on chronic steroids, steroids would usually be restarted. We usually give restart after 3 to 4 days of surgery. So if you restart after 3 to 4 days, by then the inflammatory response would have taken place, and then steroids will not hamper with wound healing. But if steroids are being given right from the starting, then they will affect the inflammatory phase and they will hamper wound healing. Okay, so you should know these factors. You should know infection is the most common factor, and you should know about these two. These two have been asked in the exam. In fact, one more thing which you should know, that the effect of steroid on wound healing can be countered by topical application of vitamin A. Right? So if a wound is not healing because of steroid use, topical application of vitamin A can help in that healing process. Now, the next thing which I want you to know, that wound healing, what are the various types of wound healing? So you can have wound healing by primary intention. Primary intention is when I've made an incision. Primary intention is when we make an incision and the wound heals after we've sutured it. So we've sutured it and we get a good scar. We get a good cosmetically looking scar. That is healing by primary intention. So the best kind of scar we will get when healing is happening by primary intention. And over the course of so many modules, I've shown you so many incisions where we've made an incision and we've sutured it. So all that is healing by primary intention, right? That is by primary intention. Now, sometimes there can be healing by secondary intention. Healing by secondary intention is when the wound is infected. When the wound is infected and it cannot be sutured. It cannot be sutured. Right? So abscesses or infected wounds, like I've shown you in the SSI, the surgical site infection module, I showed you so many pictures of infected wounds. Such wounds I cannot suture in the first go because sutures won't heal, won't hold there, right? They will cut through. So such wounds are left open. They are left open. And they will close gradually. They will close gradually, and that is called healing by secondary intention. Now, you have read in pathology that healing by secondary intention, it takes more time. It is more time consuming than healing by primary intention. There is more granulation tissue. There is more granulation tissue. There is more wound contracture. There is more wound contracture. The myofibroblasts are acting here and there'll be more wound contracture which will be there. And you get a cosmetically bad scar. You get a bad scar there. And there is a tendency when healing is occurring by secondary intention, there's a tendency to form hypertrophic scars and keloids. So there's a tendency to form hypertrophic scars and keloids. Okay. So these are the differences between healing by primary intention and secondary intention. Now, this is what you've read in pathology. One additional thing which we do is healing by tertiary intention. Right. So tertiary intention is that when the wound is infected, we initially leave it open. We initially leave it open and we just do dressings. Okay. So like this was a routine norm in the unit where I was doing a post-graduation, that supposing we used to get a patient with a perforation, right? A ileal perforation where there was a lot of fecal matter in the abdomen. We did not close the skin in that patient. So we used to leave the skin open. We used to do dressings for 4 or 5 days. When we were sure that the wound is not infected, we used to resuture the wound. Okay. So initially we leave it open, and after a few days, when granulation tissue has appeared, when granulation tissue is present and there is no infection is there, then we resuture. So this is known as delayed primary closure or healing by tertiary intention. So what is the advantage of this? This has taken into account the advantages of both primary and secondary. Right? So we are initially leaving it open, we treat the infection, but then we suture it so that we get a good scar. Okay, so this is healing by tertiary intention. Now, one more thing, patients will come to a plastic surgeon because they want a good scar, because they want a good scar and a cosmetically better scar. So what are the factors which lead to good scars? Which lead to good scars, right? So these factors are, again, we can divide them into local factors and systemic factors. So local factors, and you can have systemic factors. Systemic factors would be good nutrition, avoid smoking. So another systemic cause which hampers wound healing is smoking. So avoid smoking. This can also affect the collagen synthesis. So good nutrition, avoidance of smoking. Local factors which you should know, that incisions should be made along Langer's lines, or relaxed tension lines, right? So sometimes these Langer's lines are lines present all over the body, and if you make an incision along these lines, you get a good scar. But the problem with Langer's lines was that Langer's described these lines in cadavers, and sometimes the orientation of these lines can be different in cadavers and in living human beings, which is why we either follow the Langer's lines or the relaxed tension lines. If you have to mark in an MCQ, you will mark Langer's lines as the correct answer. So we avoid incisions perpendicular to Langer's lines, okay? Avoid tension. This I've been talking about. Avoid tension, because if tension is there, sutures will cut through. Also, the healing will not be proper. So early removal of stitches should be there so that marks are not left behind. Subcuticular sutures can be used. Finer sutures, finer thread will give rise to better scars. That is why if I have a patient who's very look conscious and wants a very good scar, I will use a 4-0 or 5-0 to do subcuticular suturing, okay? Also, it has been seen that sutures are better, or the scars are better in elderly patients. Why are they better in elderly patients? Because of the wrinkles which are present. The scar gets hidden in those wrinkles. So scars are better in elderly patients. So these are some practical points which you should remember, because sometimes they can ask you clinical questions like this as well regarding wound healing. Now, up till now, we've spoken about normal wound healing, but there can be aberrations in wound healing as well. And the common aberrations are keloids and hypertrophic scars. Again, for the FMG exam and for final year students, this is a very common short note which is asked, the difference between keloids and hypertrophic scars. So you should know about them. Keloid is when there is exuberant proliferation, right? And that can give rise to a keloid. And the remodeling doesn't happen in keloids, right? The remodeling phase doesn't happen in keloids at all. So keloids, most common site is the sternum. This question has been asked many times. The other sites are ear lobule and the shoulder. Hypertrophic scars are commonly seen on extensor surfaces, okay? Keloids, there's a racial predisposition, more common in dark-skinned patients, whereas hypertrophic scars are more common in children. The main difference with which you can differentiate a keloid from a hypertrophic scar is that in a keloid, the tissue grows beyond the boundary of the scar. Whereas in hypertrophic scars, it remains within the boundary of the scar. So this is the main point of difference between the two. Keloids, it remains red, itchy and tender. And it does not settle with time and pressure. Whereas hypertrophic scars will settle with time and pressure. And the treatment for keloids, this has also been asked many times. Treatment for keloids is intralesional steroids or intralesional triamcinolone. Triamcinolone is a long-acting steroid which we give to reduce the keloids. Whereas hypertrophic scars with silicone pads, gels, pressure dressing, it will settle with time. It will settle with time. So I just want to tell you that while playing cricket, I had a split webbing, right? I was taking a catch and the leather ball, it split my webbing. Right, so this was my left hand, this was my operative hand, so I had to be very careful. So the plastic surgeon took sutures here. She did a very good job, but because of the site, I started developing a hypertrophic scar here. So, and it was very odd for me because I was having difficulty holding the pen, I was having difficulty holding the scalpel. So then she had prescribed silicone dressings or silicone pads to me, and with those silicone pads, when I applied it for a few weeks, the hypertrophic scar settled down, right? So hypertrophic scars will settle down with time and silicone pads and pressure, whereas keloids don't settle down at all. This is a typical keloid over the sternum, which is the most common site. I've told you treatment is intralesional steroids. Now, if you do a search, there are certain tribes in Africa where there is a great tendency to form keloids. And you should see how people turn adversity into opportunity, or how they use it to their benefit. So what these people do is they deliberately induce keloids in the tribe members, and once those keloids develop, they look like jewelry or they look like ornaments. So sometimes they're so elaborate that you will see these chains running all over the neck in such a symmetrical manner, and they're actually keloids. Right, so that I just wanted to share that example, that sometimes these altered wound healing habits are being utilized by tribes to actually give it a cosmetic appearance. These are hypertrophic scars in a burns patient. This I've shown you in the burns section as well. This patient had multiple burns, and you can see the hypertrophic scars developing there. So these were about altered wound healings which can occur following injury or trauma. So one more thing which I want to highlight is regarding tissue expanders. Now this is specifically a high yield point when it comes to the INI CET exam or the super specialty exam. So where do we use tissue expanders? Now supposing, I'll give you two scenarios. Scenario number one, there is a patient where I've done a mastectomy. And now this patient wants an implant reconstruction. Okay, she wants an implant to be placed. But what is the problem? That she has a flat chest here. I had removed the breast and there was a straight line. Now there is not enough space for me to put in an implant, because if I forcibly put it, the skin will not heal over it. Okay, so what I do there is that I'm going to put an expander like this, and I will gradually inflate the expander, right? Every 2 weeks we call the patient to the OPD and we push some saline into the expander. So this gradual expansion leads to more redundant skin there. And once that pocket has formed, then we can replace the expander with an implant. Okay, like you can see in this patient, you can see that there is scarring here. And when this scarring or tumor is removed, there is going to be a huge defect. And when there is a huge defect, there will not be enough skin to close it. So before the surgery, we put in an expander. Right? With this expander, there's going to be gradually, when we inflate it, there's going to be more skin which is going to form here. So when we do the resection, then we can do primary closure. So tissue expanders uses mechanical stimulus to induce tissue growth so as to generate more soft tissue. Okay, so with this mechanical growth, more soft tissue is generated. It increases the surface area first by stretching and then by actual growth of the skin flap, which is what I told you. And if you see the area where a expander is put, there are certain histological changes. There is dermal thinning, there's epidermal thickening, the fat becomes thin, there's subcutaneous fat atrophy, but there is no effect on skin appendages. So this expanded skin will have normal hair as well, Now there are certain areas where tissue expanders will not do well, and this is written in Sebastian. Areas where tissue expanders don't do well, areas where expanders don't do well are beneath are beneath skin grafts in post irradiated tissue. If you've done radiotherapy, then that area also expanders don't do well below that skin. And the most common cause why expanders don't work, the most common cause why expanders don't work, the most common cause why expanders don't work are if too small a pocket is created. If too small a pocket is created, if too small a pocket is created for the expander, then it will not heal. The skin over it will not heal. That is the most common cause why expanders fail. So that was regarding tissue expanders. So let's talk about the final topic in this module, that is cleft lip and cleft palate. This is a topic from which both short notes are also asked and MCQs are also asked. Now, regarding the surgical anatomy of cleft lips and cleft palates, Dr. Raviraj has covered this in great detail, where he's told you about the embryogenesis and why these abnormalities develop. Now, cleft lips and cleft palates are seen in 1 in 600 live births. Males are more commonly affected than females, and the most common defect, this question has been asked, is combined lip plus palate. The risk factors can be environmental and genetic, factors. So this condition does have a strong genetic predisposition also. Environmental factors which are there are if the mother is on epilepsy drugs, like phenytoin. So if maternal epilepsy is there and drugs are being given, and steroid intake is also associated with this. So steroid intake in the mother is also associated with cleft lip and cleft palate development. Also, one of the genetic syndromes which are associated with cleft lip and cleft palate is Pierre-Robin sequence or Pierre-Robin syndrome. And Pierre-Robin sequence or Pierre-Robin syndrome is retrognathia, right? Which means there's a posteriorly displaced tongue. There'll be a posteriorly displaced tongue in these patients, which can create a problem with the airway as well. And there is isolated cleft palate. There is isolated cleft palate in patients with Pierre-Robin syndrome. Now, the next thing is when you see this patient is to document the abnormality, and this documentation system has been mentioned in Bailey, and there was a question in the All India exam 4 years back regarding this documentation system. So this documentation system is known as the Lahasal system, to document cleft lips and cleft palates. The Lahasal system means L is for lip on the left side, A is for alveolus, H is for hard palate and soft palate, S is for soft palate, which is common for both. Again, A is for alveolus on the other side and L is for the lip on the other side. So this is the Lahasal system to document cleft lips and cleft palates, which you should know about. Now, how is the documentation done? If we write it in capital letters, then it denotes a complete cleft. Whereas if we write it in small case, then it denotes a partial cleft. Okay. So for example, a patient has complete cleft lip on one side and partial alveolus on the same side and partial soft palate abnormality. So what will be the documentation? So complete lip on that side is capital L. There is partial alveolus small a on that side and there is partial soft palate. So capital A, small s. That is how we document the abnormality, and this is a universal documentation system. So if this is written somewhere, you can find out or you would know what abnormality does that child have. Now, once we've documented the abnormality, we have to manage these patients. Now, in the management, we first have to understand that what are the problems in patients with cleft lips and cleft palates. So what are the problems in patients with cleft lip and cleft palate? Number one, of course, it is a cosmetic problem. Of course, it is a cosmetic problem. That is number one. Number two, it can affect the speech development, right? Speech development. There are certain letters which these patients cannot pronounce, and it gives an altered sound. Number three, the child can have difficulty in sucking milk, right? So in feeding problems can be there in patients. And those who have cleft palates, they can also develop recurrent middle ear infections. So these are the problems in patients with cleft lips and cleft palates, right? So when we have to carry out surgery, what are the principles of surgery? What are our aims when we have to carry out surgery in these patients? So the principles are we have to do cosmetic correction. There is proper speech development which occurs. And feeding can be done properly, right? So proper feeding can happen. So these are the aims when we have to carry out surgery in these patients. Now, surgery, we have to carry out surgery for the cleft lip, for the cleft soft palate, and for the cleft hard palate. Now, the timings of surgery are the ones which have been asked most frequently in the exam, right? So, timing has been asked in the exam. So, cleft lip, the surgery done is known as the Millard repair. The Millard repair is the most commonly done repair for cleft lip. This has been asked in the exam. The Millard repair is the most commonly done repair for cleft lips. And this is done between 3 to 6 months of age. This is done between 3 to 6 months of age is when we carry out this repair. In the older books, there was also a rule of 10 which was mentioned, right? There was also a rule of 10. I'm just telling you this. This is not there in the latest Bailey now. It was there in the previous editions, that when the 10 gram percent hemoglobin, 10 weeks of age and 10 pounds weight, right? That is when the surgery was carried out. But please remember that 3 to 6 months is when we have to carry out the surgery. And you can do both unilateral and bilateral lip repair in the same sitting. Unilateral and bilateral lip repair can be done in the same sitting. Similarly, soft palate repair, we carry out a Z-plasty. I've already told you about Z-plasties in the starting of the module. And Z-plasties for soft palate are also done at 3 to 6 months of age. So both lip and soft palate can be combined as a single procedure which are done at 3 to 6 months of age. So hard palate is the tricky one where we have to wait for at least 9 to 12 months. So surgery is usually done between 12 to 15 months. Surgery is usually done between 12 to 15 months for hard palate. And hard palate, the repairs which are done can be unipedicled repair or bipedicled repair. So you can have unipedicled or you can have bipedicled repairs which can be done for the hard palate. So unipedicled repair is the VY-plasty, which I've already shown to you. The unipedicled repair is the VY-plasty which I've already shown to you, and this is also known as the Waddell-Kilner repair. Whereas the bipedicled one is known as von Langenbach repair. So these are done for hard palate, and in hard palate we wait for 12 to 15 months because we allow for the bony growth of the hard palate, right? If we carry out surgery before 12 to 15 months, then what is going to happen? It will hamper with the development of the bony structure. Okay, so that is why we wait in hard palate. So now supposing you have a patient who has a cleft lip also plus cleft soft and hard palate. So how many surgeries would be required in this patient? So if this patient has all three things, the first surgery The first procedure is done at 3 to 6 months of age, and in this procedure we are going to repair the cleft lip. We will repair the cleft lip, and the soft palate will be repaired in the first stage. Okay. The second surgery will be done at 12 to 15 months. The second surgery will be done at 12 to 15 months, and this is where we are going to repair the cleft hard palate. This is where we will repair the cleft hard palate, and here in the second phase we will also correct the other abnormalities, from the previous surgery. So supposing you have to do revision surgery for the lip and the soft palate, that you can do when you're doing the hard palate repair. So this is the sequence which you should remember for the exam. So this is a patient with a cleft lip. You can see the cosmetic abnormality which is there. These children can also have problems in speech and in feeding. Now, what are the complications of surgery? Complications of surgery, of course, hemorrhage can be there, infection can be there in these patients. There can be a malaligned Cupid's bow. Malaligned Cupid's bow. What does that mean? Malaligned Cupid's bow. So if you see the lip, if you see the upper lip, this shape which you get is called the Cupid's bow appearance, right? It looks like a bow, so you get the Cupid's bow appearance. Now, when you're doing a cleft lip repair, it is very important to align the vermilion border, right? This pigmented border or the vermilion border needs to be aligned. So when you're suturing the vermilion border, the two pigmented ends should be aligned properly. If they are not aligned, then you will get one would be slightly up, one would be slightly low, and that is called as a malaligned Cupid's bow, which is a cosmetic abnormality, which is a cosmetic problem. And the fourth one which has been asked in the exam is velopharyngeal incompetence. Velopharyngeal incompetence. So velopharyngeal incompetence is seen in cleft palate repair, and here what happens that the palate moves up and down like a flap, right? So palate moves up and down like a flap. So palate moves up and down like a flap, and this gives rise to speech abnormalities. When we speak, the voice will not be clear. That is velopharyngeal incompetence. So these are the complications regarding cleft lip and cleft palate surgery which you should know about. The most important thing, of course, is the timing of the surgery, which I've already told you. With that, we come to the end of this module. For final year students, the questions from this module, the short notes which you should know differences between split thickness skin graft versus full thickness skin graft. You should know differences between keloid versus hypertrophic scars. Short note on bed sores are asked frequently. Short note on cleft lip and cleft palate is asked in your exam. Okay. So these are the points which you should know about for your university exams from this module. Before we end this module, let's do some MCQs. So we have to identify the grade of pressure shown here. This is of course grade 4. This is wrong. This is grade 4. This is a grade 4 pressure sore because we can see the muscle here. And we've discussed that if you can see the muscle or the bone, it will be grade 4 pressure sore. Which of the following are the phases of wound healing? We have to arrange them in correct order. This I told you has been asked in the exam. So it will be 4, which is hemostasis, then 3, then you have 1, and then you have 2. So hemostasis, inflammatory, proliferative, and remodeling, that is the correct sequence. In a 2-day-old traumatic injury, which of the following would be seen on histopathology? 2-day-old, inflammation would be at its peak. So we will see neutrophilic infiltration. Okay. Fibroblastic activity you will start seeing from the 5th or the 6th day. Which of the following is an anti-inflammatory cytokine? Anti-inflammatory is IL-10. IL-10 is anti-inflammatory. This question has been asked in many exams. Dr. Ila has also covered this. This IL-1, IL-6 and TNF-alpha, they are implicated in They are implicated in SIRS. What is SIRS? Systemic inflammatory response syndrome, which I've covered in the module on shock. So just by elimination also, you can remove these three and you'll just be left with IL-10, which is the anti-inflammatory one. Prednisolone affects which phase of wound healing? This I told you is the initial inflammatory phase and angiogenesis. Which of the following are signs of arterial occlusion in a free flap? So increasing warmth. No, if the artery is blocked, the flap would be cold. So this is false. The flap would be cold. This is correct. The flap would be pale. That is correct. Sluggishness on pinprick bleeding is correct. Increased congestion is also false. This will also be a sign of venous blockade. Okay. So 2, 3 and 4 are correct. And finally, what is the pressure involved in vacuum assisted closure? It is minus 125 millimeters of mercury. VAC is very important from the point of MCQ. Lot of questions have been asked from it. So that brings us to the end of this very, very important module. And you can expect at least 1 to 2 questions from this module in various MCQ exams. Thank you.